Stevens-Johnson syndrome after carbamazepine and SJS-10 overlap syndrome after amoxicillin. Case reports and a review. Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN or TEN, are both part of the erythema multiforme disease spectrum. These conditions can result to acute life-threatening dermatosis characterized by extensive epidermal sloughing at the dermo-epidermal junction, resulting from keratinocyte apoptosis. Literature has described SJS involving epidermal necrolysis of 10% of the body surface, while patients with widespread macules or flat targets that involves 10 to 30% detachment are considered to suffer from SJS-10 overlap syndrome. Case number 1 presented was a 54-year-old woman suffering from acute generalized skin eruptions and mucosal erosions. Severe desquamation all over the body was observed, and Nikolsky sign was positive. Erythematous macular lesions showed rapid confluence. The patient showed severe mucous membrane lesions of oral, conjunctival, and genital areas. Eroded lesions on the lips were covered with hemorrhagic crust. She had acute ocular findings such as purulent conjunctivitis with severe eyelid edema and pseudomembrane formation. Systemic symptoms included fever, sore throat, and dysphagia. The patient was also suffering from other systemic concerns including agoraphobia, insulin-dependent diabetes, and arterial hypertension. The main laboratory findings were leukocytosis, sedimentation rate of 64/107, the presence of bacteria, leukocytes, and erythrocytes in urine analysis, significant hypoalbuminemia, and higher level of transaminases. Case number 2 involved a 12-year-old girl with multiple skin lesions as well as oral mucosa involvement and severe conjunctival lesions. Her general state was severe at the beginning of treatment with fever, headache, and dysphagia. The dermatological examination revealed multiple erythematous lesions with blisters and large desquamation. She had eroded lesions on the lips, covered with hemorrhagic crust and severe edema of eyelids and lips. Changes in laboratory analysis included high CRP level and hypoalbuminemia. Both patient diagnosis was accomplished on the basis of clinical features. What is the etiology? Stevens-Johnson syndrome and SJS-10 overlap syndrome are necrolytic and bullous reactions to drugs that result to erythema multiforme. Results of a multinational study revealed that allopurinol is the most common drug that can cause the reaction. Common associated drugs also include antibacterial sulfonamides, anticonvulsant agents, nonsteroidal anti-inflammatory drugs, aminopenicillins, and quinolones. These are fairly common drugs for treatment of common ailments. The SJS-10 overlap syndrome in case number 1 resulted from a reaction to amoxicillin for the treatment of the patient's acute bronchitis. Case number 2 was a reaction to carbamazepine for treatment of epilepsy. This syndrome was reported less frequently after tetracycline, methotrexate, and antiviral drugs. Among drugs recently introduced on the market, strong associations were documented for nevirapine and lamotrigine, and weaker for sertraline, pantoprazole, and tramadol. Several mechanisms of pathogenesis are postulated. Some authors suggest that SJS and TEN are the result of deficiency concerning mechanisms involved in detoxification of reactive intermediary metabolites. Others postulate the role of several immunologically mediated mechanisms, including damage mediated through CD8 plus cytotoxic cytotoxic T cells, causing epidermal necrosis. The extensive keratinocyte apoptosis is at least in part mediated by the interaction of the Fas receptor and Fas ligand. Genetic predispositions and associations with some HLA antigens have also been postulated. Patients suffering from SJS and TEN need careful and often multidisciplinary therapeutic management. Patients must be daily examined for an imbalance of fluid, protein, and electrolyte homeostasis. Topical therapy is essential to reduce loss of fluid and electrolytes and to prevent infections. A protocol used for the patient presented included use of topical antiseptic solutions such as chlorhexidine and silver nitrate. It is important to keep the wounds wet to prevent progression of necrosis. The authors describe the following protocols. Changes of dressings have to be performed under aseptic conditions once daily, and a microbial test for wound infection should be performed at least 3 times per week from various body parts. There are several dressing options available for treating TEN and SJS. Porcine xenografts, synthetic dressings, dressings with occlusive silver nitrate gauze, and the traditional Vaseline impregnated gauze. Topical therapy of the mucous membrane includes repeated mouthwashes with antiseptic compounds and application of local anesthetic, as well as the use of chlorhexidine rinses and white petroleum jelly to the lips. Balanced nutrition is essential because many patients are unable to eat as a result of massive pain caused by oral mucosal lesions. Cyclosporin has been proposed as a drug with potential benefits in the management of TEN. Cyclosporin is strongly immunosuppressive and anti-apoptotic. Concerning the described cases, patients receive 3 milligrams per kilogram daily for 2 weeks, and then this dose was tapered off. The time to achieve re-equalization was about 12 days. Eye care plays a crucial role in the management of SJS-TEN patients, since ocular involvement may lead to severe complications and long-term consequences ranging from visual impairment to synesthesia formation and complete blindness. Therefore, the ophthalmologist would play an important role in the prevention of serious complications. Another possible method of treatment proposed by the authors was the introduction of intravenous immunoglobulin used in reported cases of SJS and TEN as a substance that significantly decreased mortality rates in patients. Intravenous immunoglobulin blocks Fas ligand binding to the Fas receptor and interferes with the downstream signaling responsible for apoptosis. In the described cases, disease progression was rapidly interrupted and the patient survived. Patients were treated with doses of immunoglobulin ranging from 0.2 to 0.75 grams per kilogram per day of intravenous immunoglobulin over 4 consecutive days. Other treatment specifics for the case for case number 1 included intravenous fluid replacement, steroid intravenous therapy with dexamethasone, Cipro because of urinary tract infection, and systemic control of glucose level. Case 2 had the following treatment. Carbamazepine was stopped and was replaced with Depakote chrono. Fluid balance, nutritional status, and pain relief was provided. Hydrocortisone intravenously was given during 9 days, 3 times 150 mg tapered systemically, and later 30 mg of prednisone tapered during 3 weeks. Although the corticosteroid was utilized, In the 2 cases reported, controversy exists in the use of systemic corticosteroids, as some investigators have reported that it can provoke prolonged wound healing and increase risk of infection, hiding early signs of sepsis, severe gastrointestinal bleeding, and increased mortality. Some clinicians have included daily plasmapheresis over a period of 3 days into their treatment. It is well tolerated and aims at the elimination of drugs and drug metabolites and inflammatory cytokines. In my clinical experience, I have encountered erythema multiforme once. It is encouraging to see that a condition with such dramatic and debilitating change in patients can be successfully treated.